Good morning. I think we're in a position to begin with today's witness.
Yes, my lord. Today's witness is Dr. Penelope Redding, my lord.
Good morning, Dr. Redding.
Good morning.
As you understand, you're about to be asked questions by Mr. McIntosh, who is sitting opposite you. But first, I understand you're prepared to take the oath.
Yes, I am.
Sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much, Dr. Redding. Now, as far as timing is concerned, I anticipate your evidence may go into the afternoon. We usually take a break about 11:30 for coffee, 20 minutes or so. But something I say to all witnesses is that if you want to take a break at any time, all you need to do is indicate that and we'll take a break. So I'd like you to feel that you're in control of the situation.
Thank you.
Ms. McIntosh.
Thank you. I wonder if you could state your full name, please.
Penelope Jane Redding.
Dr. Redding, did you produce a statement for the inquiry?
I did.
Are you willing to adopt that as part of your evidence?
I am.
Now, we've read the statement, and it's a long and comprehensive document. And what I'm not proposing to do is to go through it section by section, but rather to pick up parts of it that appear to be of interest to the inquiry. So please don't think that we haven't read the parts I don't touch on, because we have read them and taken them on board. You explained in your statement that I want to get some dates right before we start. You explained in your statement that you became a consultant microbiologist in 1984, and you retired in March 2018.
That's correct, yeah.
I take it that by the time you retired, you must have been probably the longest serving microbiologist then in the city.
Yes, probably at the time, yes.
Yeah, and I want to just check a few bits of the chronology I've understood correctly and maybe connect them to other things that other people have done so I can put it in context. I understand you were the lead ICD for the Southern General University Trust until August 2008. Have I got that right?
Yes, I was the infection control, but it wasn't called the lead.
It wasn't called the lead.
It wasn't called the lead ICD at the time. That was more formalised when the new structure came in. So
it was just called the infection control doctor?
Yes.
Yes. Were you the only one?
Well, there were other infection control doctors under.
But they were under you, right?
Yeah.
So although it wasn't called the lead, nowadays we would see it as that.
Yeah.
Yes. And that, in a sense, that means that you were one of the predecessors of Professor Williams when he was the lead ICD for the whole board around the time the new hospital opened.
Yes.
Because
when I gave up infection control, that was a new post, the lead ICD for Glasgow. That was a new post. And I was asked if I was interested, and I wasn't at the time because I was clinical director. And that's when the first appointment was made, and that was Professor Williams.
Right. And in a sense, to some extent, that would have been a merger of all the ICDs for all the trusts in Glasgow together into one post.
Yes.
Right. Now, I want just to understand a little bit more about what you were clinical director of and when. So, you were clinical director of the Laboratories Directorate.
I was.
Until when?
We just talk about the Queen Elizabeth. I was clinical director of the Victoria Infirmary Trust for a time.
Yes.
And then from 2008 to 2011, I was clinical director for all the labs for Greater Glasgow and Clyde.
So that's after this merger process?
Yes.
Yes. And you resigned from that role in March 2011?
Yes.
And that would mean you would have been working solely as a consultant microbiologist from then on until you retired?
Yes.
Did you have any other formal responsibilities other than being a consultant microbiologist?
No, not really. I was just worked as a consultant microbiologist.
Now, we haven't yet heard from a consultant microbiologist who's just doing that. And indeed, most of the microbiologists we will hear from in the rest of the inquiry were at times having had infection control and prevention sessions, or they were lead ICD for some aspect of the services in the hospital. So it'd be quite useful just to get some basic concepts clear in our minds before we start. This sounds a very, very silly question, but what is the primary sort of work pattern of a consultant microbiologist in the final years before you retired? What were you doing on your average day, average week, if that's a legitimate question?
Would it help if I said a bit of background about
Yes, it would.
what microbiology and what microbiology does? So there are 4 major laboratory disciplines, and microbiology is one of them. And microbiology provides a service where you get specimens from patients' environment, water, which you analyze in the lab by culturing. So you're trying to grow the bacteria. There are other investigations that you might do in the lab, but on the whole, so you get specimens from mostly patients. And I think key to the process of that is that you need to know exactly where a specimen has been taken from. And part of the role of the microbiologist might be to advise the clinicians, you need to take this specimen from this patient if you've heard the story of what's going on.
It might be from a particular system within their body.
Yes,
part of their
you might
skin
say
also.
you need to take a sputum sample, or you need to take a wound, or you need to do a blood culture. So there are the various specimens that can be taken. So that either might be instigated by the ward themselves because they know what they have to do, or if there's been involvement with a microbiologist, they may give you advice on what specimens need to be taken. And just I think it's important to understand that whatever specimens are taken need to be properly. You need to know exactly where the specimen has come from.
Yes.
You need to make sure that it's properly labelled so you understand where on the patient or where in the environment that specimen has been taken. And so the information that comes to the lab has to be very accurate and very precise. So once a specimen arrives in the lab, most of the specimens, which is what I'll concentrate on, are then cultured. So we put it on culture media, agar plates.
So this is a small glass dish with a sort of jelly in it.
Yes.
Yes.
There are liquid medium and there are other things that we might do. Now, every specimen is dealt with differently. So we don't process every specimen in exactly the same way. So it depends what you are looking for.
So if you're looking for bug A, you will process it in a way that will encourage bug A to grow, effectively.
Yes.
Right. But that won't necessarily be a way that would encourage bug B to grow.
No.
Okay.
So you obviously have a standard operating procedure in the lab that will say, right, this is this specimen, these are the plates.
Yes.
So, for example, if you're talking about a feces specimen, there's maybe 12 or 15 different ways that you could actually process it. And so
you would pick the ones that you thought were relevant.
Yes, and that depends on the history of the patient, for example, if they've travelled abroad or something in that particular instance. So depending on the history of the patient, you will then decide which plates are put up. And there are some special plates that will grow organisms that won't grow on standard plates. Does that make sense? So there are some bacteria that have growth requirements that require special agar plates to be.
And that's because of the nutrients or the
Yes.
pH or something on the plate.
Yes, all sorts of things. And also if you're taking a specimen from something like a throat swab where you've got a lot of normal bacteria, you might have to put up plates that stop up those normal bacteria growing to allow the ones you're looking for, so the pathogens, to grow through.
So you want to discourage the things that you know are there anyway but don't care about.
Yeah.
Right.
And encourage the ones, because some of them are very small or some of them have particular growth requirements. So that's a skill in the laboratory of how you process a specimen.
But that's very helpful. Before we move on to the rest of your explanation about what a microbiologist is doing in the laboratory, for an environmental sample, it's broadly the same sort of problem of working out what you're sampling. Does that apply for environmental samples as well?
Absolutely. Any samples that come in, you would decide what you are looking for. So if you're having an environmental specimen and you're looking for a particular organism, you would make sure that the plates that you put up on that specimen will allow the growth of that particular organism.
So just before, as a slight distraction, but you're helping me understand a few things. If you have a plate and you put your sample on it, your environmental sample, do you, once it's grown, do you look at every single sample on the plate, or do you select certain growths on the plate to look at further?
Well, you've probably got more than one agar plate.
I see.
So, you might have 3 or 4 different plates. For example, you may be looking for the organisms that need oxygen to grow and the ones that need no oxygen to grow.
Yes.
So you have to put that in an environment. You would look at the plates and you would hopefully recognize the colonies, or you'd have an idea looking at the plate. Oh, that looks like Staph aureus, or that looks like Pseudomonas. And then you would, so that the organisms or the colonies on the plate might have different appearances, and so what you would then try and identify, select the organism that you think is of interest,
Right.
and then you would go and do further work on it.
So you effectively look at a particular colony on the plate because you thought it was relevant.
Yes. So when you get a specimen in the lab, it would be 24 hours before you can actually look at anything, because it has to be incubated. And again, they may be incubated at different temperatures, depending, because again, some organisms have different growth requirements. So you look at the plates at 24 hours, you look at them again at 48 hours, you look at them again maybe at 5 days, 7 days, because some things, if you're looking for tuberculosis, sometimes it maybe takes 6 weeks to grow. So again, depending what you're looking for, you have to ensure that you have the requirements for that particular bacteria.
That's very helpful. So you started on this explanation because I asked you about what, in effect, microbiologists you were doing as a consultant microbiologist, and you wanted to explain a bit more of the role of a microbiologist. So if we get back to that, the role of the microbiologist, you've got the advice, you've got the growing the samples. Any other particular aspects you consider important?
Well, if you're looking for obviously you've got to identify the organisms that you grow, and there are laboratory methods for doing that. And then, if it was in a particular patient sample, you would then have to do antibiotic sensitivity testing, so that you could give relevant antibiotic advice depending on the sensitivity of that bacteria to different.
And would that involve applying antibiotics to the plate, effectively?
Yes, you take off the colony on the plate, and you then put it up against a batch of different antibiotics on a plate. So, and where there's no growth around, there's a little disc, a little filter paper disc
with sort of cones out, wedges for each antibiotic.
And you get so it's a circle that has the antibiotic in it, and then you measure the size of the circle where there is no growth on the plate.
Yes.
To decide whether it is sensitive or resistant to that particular antibiotic. So again, you select which antibiotics you test according to the bacteria that you're testing.
And presumably that takes time as well.
Yeah, so probably to get at something with a straightforward specimen, it would be 48 hours before you probably had sensitivity testing. Or there are now automated methods. It can maybe be a little bit quicker than that, but you're probably talking sort of 48 hours on the whole to get a result, to get the full result.
Right. And in terms, that's the sort of testing, reacting, antibiotic resistance. Is there any other particular key parts of the microbiologist's sort of day-to-day job that you would want us to understand?
Well, so specimens come into the lab, they're analysed, we go through the standard operating procedures, and then as the results are produced at each stage, one of the technical staff and biomedical scientists might draw to your attention that there is a problem. So we might not be able to produce a report, but they might come to you and say, "Oh, we've got a group A strep in this specimen," or "We think we've got salmonella," or along those lines. So at each stage of the processing, the microbiologist, we would have key organisms that we asked to be alerted about, and they would come, and you might then have an intervention with the clinician on the ward.
So you go and tell the clinician effectively.
Well, we think this patient may have so and so, and we would give antibiotic advice.
And would you also And so at various points in the last couple of weeks, infection control and prevent nurses have explained to us how the infection prevent control team would be told by the lab about a certain microorganism. Is that happening at the same time as you're telling the clinicians?
Yes, oh, yes, absolutely.
This question seems important, but for later events. How do you know what's important? How do you know whether to tell the infection prevention control team of a particular thing?
Well, if you, I mean, you've heard about the alert organism list, so you've got
Yes.
your alert organism list. So any organism where you think there may be a risk of cross-infection to another patient, where you maybe need to put infection control measures in place. So if you had a group A strep, that was something where you would say that patient needs to go in isolation, or you might say looks as if this patient might have salmonella, put them in isolation, and it may well be at 48 hours or later that turns out not to be, so you can then remove the precautions. But at the earliest stage, the microbiologist or the infection control doctor, you might tell the infection control doctor, or the microbiologist might just inform the infection control team of the alert organisms or anything else that you thought might be relevant. So if you know, for example, you've got a possible outbreak with Klebsiella in the hospital, every microbiologist should understand that. So if they get a Klebsiella that's linked to a potential outbreak, that they would know, because the infection control doctor doesn't see all the results. There's thousands going through every day. You would know to alert the infection control team, even though that was not an alert organism.
So you've got the alert list. You've got things where there's an obvious consequence of reinfecting other patients.
Yep.
And so things that aren't on the alert list, for that's true, you tell people about them. You tell people about infections of a type that's already been noticed in the hospital and is, as it were, being paid attention to. But we've also heard a lot about unusual microorganisms. What do you understand by the expression of unusual microorganism? It gets bandied around a lot.
I suppose in my simple brain, I would be saying things that you do not see very often. Now, if we're talking things like Stenotrophomonas and some of the other organisms that have been talked about, those are things that you just do not see very often.
And so how do you ensure, as a microbiologist or even a clinical director for laboratories, that the scientists in the microbiology labs are flagging these unusual microorganisms up the tree, as it were?
Well, we would usually have a meeting every morning with all the consultants and the people, so that you'd have the duty room.
And this is within the microbiology?
Within microbiology, and there that you should be briefed on the problems or things we're looking for. So and so, for example, you might say, well, we've had 2 patients with Pseudomonas that's resistant to gentamicin, which is unusual. If we have any more, we need to, we're not sure if there's something going on, but we just need to be aware of it. So you need to alert.
So I understand how the alert list triggers action. I understand how things we are worrying about, because they're already, as it were, in the hospital to some extent, we need to know about more of them. And I understand how infections that have an obvious impact on other patients and staff because they're infectious would also naturally climb to the top of people's minds. But I'm thinking about the genuinely unusual. And so Stenotrophomonas is a good example.
Yeah.
In any scenario where there are more than one Stenotrophomonas infections in a hospital, and there is a discussion about whether there's an outbreak and whether there is a environmental connection, and all these things are eventually going to happen, how do you know to report the first case? Or how do you not fail to report the first case?
Well, if I suppose if there's one, you might just say we've had one case of Stenotrophomonas, and you wait and see if there's possibly another one. It's difficult to. There is also there's an element of experience around it as well,
I'm
which is
conscious of that.
which is difficult to explain. But it tends to be that there's perhaps more than one, or you've seen one 6 weeks ago, and you've got another one, and you think, that's really unusual.
Because
So
the thing
I
that
find it. Does that make sense?
it does, I want to press you a little bit further. And I'll use an example because I can, from the top of my head, I can do some dates for this. We know that in 2019, there was a Mycobacterium chelonae case in the Schehallien cohort, as it were. We read about that in IMTs. I mean, you weren't working then, but we know about that. We know from that exchange in the IMTs that there was a previous case, we know from the patient, in fact, in February of the previous year, 2018. And indeed, it's mentioned briefly, seemingly, in one of the IMTs. We're going to explore that with the relevant doctors and nurses as we go through the hearing. Our expert panel have noticed that in the bloodstream infection sample data we've received from the hospital, there seemingly was another case in early 2016. That doesn't appear to have prompted a PAG or an IMT or a report to HBS or anything. And we'll obviously find out in due course if anyone noticed at the time, and that's possibly quite important for that particular story in terms of the inquiry. But how would you have a system that could reliably spot that first infection of those three? Or is it really that you just rely on the experience, skill, and professionalism of your microbiology team?
Yes, I mean, you are relying on somebody bringing that up and alerting that this is really unusual. I've never seen that organism before.
So you can't have a
really
system, you
unusual.
have to rely on professionalism effectively.
Yes.
Right.
Yeah.
Now that was a long distraction from my first question. But what I want to do is just to move on to something that you mentioned in your statement, which is paragraph 20. Now what we'll do is we'll put paragraph 20 on the page, and it would help if I had the copy with the numbers.
Mr. McIntosh, I hesitate to sort of take you out of order, but we have heard the expression unusual infection, as you rightly
Yes.
say. I think I rather want to ask Dr. Redding why one unusual infection is of significance from her perspective.
Yes, I think I'll bring that out of sequence.
Does that sort of take you out of order?
No, it doesn't. It just if we go back to unusual microorganisms as a concept, is there any more that we can understand about what it is that makes an unusual microorganism important at the moment it's found, other than the fact you don't see them very often?
I think that's the primary thing that I mean, there are certain things that maybe I've seen once or twice in the whole of my career, and that would be certainly seen as unusual.
And if you're a new microbiologist who's not a consultant and you're a lab scientist even, and how would you know that this thing growing on the plate that presumably you weren't looking for? Because you described...
Not particularly, yes,
Yeah.
yeah.
You described how you look for things.
Yes.
So let's imagine you're looking for A, and you apply the growth medium and the temperatures and everything that helps A to grow, and serendipitously Z appears on the plate. How would someone know that is that thing?
I think from memory, the mycobacteria were from blood cultures, weren't they?
Yes.
Right. Well, blood cultures should be sterile.
Got it.
So if you've got a specimen which should be sterile, no matter what you grow in it, you've got to identify it, and you know that it should not be there.
This wouldn't be true for environmental infections, but it would be true for blood samples.
Any sample, anything, any growth that you get, you can get contaminants in blood cultures, but any sample any isolate from a blood culture has to be taken seriously.
Right. And the same would apply presumably for other, like spinal fluid as well. Others.
Any organism. There are occasions where you can get contaminants in blood cultures, and there are various reasons why that might be. But on the whole, anything in a blood culture would have to be considered and identified.
So if it's from a blood culture, the unusualness is simply that it's there.
Yes.
And then the unusual that is not common is the second unusualness.
Yeah.
And that's all you need to know that it's unusual.
Yes. I mean,
And then you don't work out what it is.
Yes, and then you have to identify what it is, and that can be difficult sometimes, easier.
Got it. So
Depends on the organism.
it's not like with an environmental sample where there could be tons of things in there and you're looking for one of them.
Or two of them, or three of them. Or whatever. It depends. It would depend. Yeah.
That's helpful. You mentioned in your statement, and I think I pick it up here, the concept of a resident organism. And I wondered what you meant by that.
Well, those are organisms that you would find on your skin,
Yes.
in your mouth. So the normal bacteria that we all have.
We all carry those.
Yeah, we all carry those, yes.
And some of us might carry slightly more concerning organisms on us, which would be a problem if we're having an operation, for example.
Yes.
And would those organisms also have a risk of being transmitted to patients in the same bay or the same ward, potentially?
Well, there is a risk of, it's not as simple as that. I'm trying to think of my way around this. Right. There are certain organisms, for example, if we just take Staph aureus, that you might have a Staph aureus or an MRSA up your nose.
Yeah.
So that was clearly a risk to you if you have an operation, that a wound might become infected by MRSA. Let's say
Yes.
MRSA, everybody's heard about that one, in your wound. So obviously, again, it is also a risk to other patients if your MRSA is spread to another patient.
And that could spread through equipment, through lack of cleanliness of staff,
or in the or airborne. It depends on the organism,
Right.
But because there are different means of different transmission. And as far as your flora, if we just call it your normal flora, concerned, that normal flora can change.
Yes.
So if you've been in hospital for a time, or you have had antibiotics, as we all know, we're not supposed to use antibiotics because it affects your normal flora, your normal flora can change. So if you are in a hospital and you're exposed to environmental organisms that might be in the atmosphere, and you've had antibiotics, the flora that you carry that's not causing you any problems at that moment in time can change.
I might acquire things from the hospital, effectively.
Yeah, so you might be carrying on your skin, or you might have it in your bowel or something like that. The flora that is yours has changed.
Right. So
does
those
that
are all the
make-
resident ones.
Well, they may then become your resident ones. They may change. Your resident microorganisms may change because you've had antibiotics or because you've been in hospital.
Now, without getting into too much detail, is it possible that some of the potentially environmental organisms that we are talking about in this inquiry are also resident on some of the patients who come into the hospital and are in the hospital, on their skin?
It's possible that's possible, yes.
Now, whilst we're on talking about definitions, I thought I'd just ask a question I've been asking. A lot of people talk about contaminated water. What do you understand by the expression contaminated water? In the context of domestic hot water system or cold water system?
Well, there are standards for water of how many microorganisms you're allowed. So the total viable counts.
Yes.
That are allowed. So for me, that would be healthy water, or would be water that ticks all those boxes, so you're only allowed a certain number of bacteria.
Yes.
And most of the testing on that sort of, on a routine sample would not be looking for microorganisms, you're just looking for total viable count.
Of any bacteria or fungi?
Yes, I mean, so it's a total thing that you have. I don't know what the numbers are off the top of my head, I can't remember, but you would say, well, you know, there are less than whatever the criteria that are quite clearly well defined. Then I suppose you've got, but within that, you might have, you're not identifying any of those organisms. So you still have, within that, you might have the total viable count, this is my understanding, would be within normal limits. But when you actually look at these colonies, which we've talked about on the plates, you might say, well, there's only 10.
Mm-hmm.
So that's okay. You're allowed 100. I'm just making those numbers up off the top of my head. But so there's only, but we don't need to identify them. But then if you think you have a problem or you're worried about the water supply having things that should not be in there, you would then go, well, we need to identify what these 10 colonies are.
Mm-hmm.
And that's when you would, I've called it in my statement enhanced testing, where you would say, well, we need to do enhanced testing. We need to look.
So enhanced testing is more than just counting the total viable counts. It's actually working out what all the total viable counts are.
It's actually identifying the microorganisms. So you may have the right, maybe acceptable limits in the numbers, but you need to identify the bacteria that are in that water supply.
So does that raise the question, I suppose that raises the question of, is it fair to say, however, that it's not possible to have effectively sterile water in a hospital? And so that looking to exclude all these bacteria is an unnecessary over vigilance. But once you go below the total viable counts, the numbers are so low that you shouldn't need to worry because water can't be sterile. It is a point of view that's been expressed.
Well, the water is very unlikely to be sterile.
Yes.
And I think a water expert could go into more details on that. That's my.
No, I wanted to see what your understanding was. That's very helpful.
But my understanding, that's my understanding of what you.
Now, I'm going to go back to your statement, but I'm going to make the depressing news to my colleague behind you with his video system that I'm looking at a copy that hasn't got page numbers on it. So I could only apologise to him for what I'm about to do. I will change that at the break. If we can go to paragraph.
Just, Ms. McIntosh, it's my fault. I just really want to make sure I'm keeping up. Ms. McIntosh's question began with, what do you understand by contaminated water? Now, do I understand that your answer to that is, well, you can look at the total viable count, which I'm understanding as everything in the water. And you then said, but you would then need to identify what it is, first of all, by identifying number of colonies and then perhaps identifying what the colonies are. Can I just make sure, as I say, I've got your answer to Mr. McIntosh's question. What do you understand by contaminated water?
Well, the routine water testing will just be looking at the total viable counts, and also they're looking for Legionella. So that's a specific thing. I think it would be linking in to if you think you have a problem, you would then say we need enhanced, like water. A part of a theory or a hypothesis would be, could it be the water? You would then, and that the clue to that would be you may be getting Cenotrophomonas or other organisms that like water. So you might, at that point, you would then go and say, right, well, we need to do what I call enhanced testing and identify these bacteria. And then I think I would start then to be really concerned if I found the organisms that you're looking for in that water supply.
Right.
Does that?
Well, what I'm taking from that, I'm just wanting to know if I'm keeping up. But what I'm taking from that is, in the end of the day, it depends on whether the water supply contains particular microorganisms which, from your perspective, are significant. I'm assuming from your perspective is significant, is their potential to give rise to important infection.
Yes, in certain groups of people as well.
In
I
certain
mean,
groups of people.
for a healthy person, you probably wouldn't be as worried as you would be for an immunocompromised patient.
Right. Thank you. As I say, just
Sorry,
making sure that I'm
not a water expert. I'm just trying to, in my head, that's how I would.
right. Thank you.
Thank you. So if we can go to your statement, which is paragraph 20, page 9 of the statement, but it's not page 9 of the bundle because it's 72. What number do I need to enter? Page. The next page, please. Yes. Now, I'm looking at this paragraph 20. You discussed briefly structural changes made to the infection prevention control team in the aftermath of the Vale of Leven report. Do you remember setting this out in your statement? You've explained that the IPCT structure, the infection prevention control team structure, was put into place at that point, and the managerial function was removed from the laboratory directorate, because you'd been the clinical director for laboratories in the previous trust.
Yes, I have.
Yes.
Yeah.
And I believe it was given to the ICM and the lead ICN. Now, the ICM is the infection control manager,
Yes.
and the lead ICN would be a nurse, senior
Yes.
nurse consultant. Yeah. And the director of laboratories had always been a microbiologist in the past. Or the head of the laboratory directorate, would that always have been a microbiologist?
Well, yeah, you've got your diagnostic directorate, and that has a medical director, and then you've got and within that you've got imaging and the laboratory directors, and within the laboratory director you'd have the clinical director of laboratories.
And that would be a microbiologist?
Yes.
Right.
No, sorry. That would be a medic.
Medic.
That could be a pathologist, it could be a hematologist, it could be a microbiologist, a biochemist.
But it would be a medic?
It would be a medic, it would be a consultant.
That's the point you're making there?
Yes, it's a consultant.
So what in a sense is wrong, because you then go on to say, in my view, these changes are the start of fundamental problems of infection control in Glasgow. So what is wrong in your eyes with putting the managerial function for infection prevention control into the hands of the infection control manager and the lead ICN, as opposed to the medic in the laboratory directorate?
Well, when infection control was within the laboratory directorate, the general manager for the laboratories worked very closely with the infection control doctors and the infection control nurses, and it worked very well. It worked very smoothly. Now, whether that was because of personalities or but it worked well because you rely on the microbiology lab, and it's all under the same management.
So you have the lab and the infection prevention control team in the same management structure?
So that, yes, the general manager would be the general manager for all the lab disciplines, including microbiology, pathology, hematology, blood transfusion, etc. And they would be responsible also for the running of the microbiology and the delivering of the service. You can't have an infection control service without a microbiology laboratory. So they are managerially responsible for ensuring that the microbiology department delivers microbiology service and an infection control laboratory part.
But is it your understanding that under the new system that you're talking about being created here, the infection prevention control team is separate from, in managerial terms, the microbiologists in the lab?
It is. That's where it gets quite messy, because you've got the microbiologists and the infection control doctors reporting through two lines. So they report within their responsibilities as a microbiologist, in fact, through the laboratory directorate, and from an infection control point of view through the infection control. Now, I was never really involved with the whole new structure, so I'm just seeing it a little bit from the outside.
I appreciate that. And you make the observation at the beginning of this paragraph that these changes were made in the aftermath of the Vale of Leven report.
Yes, that's my
To what
memory.
extent do you understand whether the reasoning behind the changes it derives from any recommendations of that report?
I think it was a recommendation of the report that a new structure was put in for infection control. That's my memory of it, but it's
Right.
quite a long time ago now.
So do you feel you have some, as it were, disagreement with the authors of the Vale of Leven report about whether this is a good idea?
I just think from experience, it just didn't seem to work, I think, so maybe they thought it was a good idea at the time, but my experience was it didn't seem to work.
And that's because of the split management.
Yes.
So just to check the split management, so if we think of an imaginary microbiologist with infection prevention control sessions in their job plan and on-call responsibilities, they were being managed by the infection prevention control team for their infection prevention control sessions and on-call, but for their microbiology sessions, they were managed by the microbiology director.
Well, it wouldn't be the on-call. They're not on call for infection control. So
Right.
it would only be their infection control duties that they would report managerially
So
to.
for the sessions they have for infection prevention control, they're managed by this new system.
Yeah.
Everything else they're managed through
Yeah,
the
and
director.
so they're out of hours. Every microbiologist, unless there's a major outbreak or something, there's no out of hours infection control doctor, unless they happen to be the infection control doctor on call. So quite often it will be a microbiologist who has no infection control sessions, but all microbiologists have an infection control responsibility.
So if you're a ward and out of hours or more practically over a weekend, an issue arises about a ongoing thing that is generated at IMT, for example, there's no on-call infection prevention control doctor. So you would be going to the on-call microbiologist for advice, who might not have any infection prevention control sessions themselves, but they would be the person who answers the phone when you want some advice.
Yes.
Would there be an out-of-hours infection prevention control nurse?
No. There is an exception to that, though. If there was a major outbreak or a major problem, then on an ad hoc basis, an infection control doctor and infection control nurses might be brought in over the weekend if we needed to have meetings, or there is a big problem like 6 wards shut because of norovirus or something like that. There would be the microbiologist couldn't cope with that workload on top of everything else at the weekends. But that on the routine basis, the microbiologist would need to be informed about what was going on. And if it was a question of ward A is shut, if we get any more cases, this is what you need to do over the weekend. And it would be relatively straightforward. But there are occasions when the workload was increased and these people would be brought in.
I want to just understand this a bit clearer, because if we compare it to a clinical function, if you had a clinical function in the hospital, say hemato-oncology, one of the functions within that, there would be an on-call consultant for that function all the time, out of hours, all the time. And nurses would work shifts in the wards. So there would be a nurse in charge of the ward, and clinical nurse specialists would work shifts. Is that the normal arrangement for a normal treating ward? You'd have
Yes,
right,
yes, absolutely.
So out of hours, the same pool of people are providing the service, either through shift patterns if they're nurses, or on call if they're consultants and registrars. Is that broadly right?
Yeah.
Right. So in the context of infection prevention, control and microbiology, technically, infection prevention control is an in-hours only service, unless there's an exception.
The microbiologist takes on the responsibility for providing the infection control advice. Most of the advice would have been given during the day. There will be a program set up. The ward will know what they need to do.
Yeah.
If there's something that comes in overnight. Usually the microbiologist will have the knowledge and the experience to know, right, well, that patient needs this, we need to isolate that patient, and in the morning, you would then inform the infection control nurses. So the microbiologist takes on the role, if you like, of an infection control doctor and an infection control nurse out of hours. And only when the workload is there's a big problem, would they actually be coming in. But if you were stuck, there would be nothing to stop you ringing somebody at home to say, I've got a problem.
Right.
There isn't anybody formally on call in those situations.
Yeah, I need to sort of break this down a bit, as it were, for us as a lay audience. You mentioned a plan. In a conventional specialism where people are treating patients, the individual patient might well have a plan for their treatment. That will be relatively common in a hospital. And so when the out-of-hour call is made to a consultant who's a different consultant from the consultant responsible for that patient in the day, they would presumably try and work to the plan. Have I got that broadly right?
Yeah.
But the consultant who is taking the call out of hours is in the same team, management team, as the other consultant whose patient it is.
Yes.
They just might be the other one of three others or something in that specialism. But do I have it right that in this environment, under the new system that you're talking about in paragraph 20, the out-of-hours call goes to someone who's not in the same managerial structure as the infection prevention control nurses and manager, and indeed the lead ICD as well? They're in a different managerial structure.
Well, not absolutely. This is where it becomes. They're in the microbiology structure,
Yes.
in which the infection control doctor is part of that managerial structure as a microbiologist. So from a briefing point of view, from handing over information point of view, that it's exactly the same as it is on the wards. They are within that managerial reporting line in their role as a microbiologist.
But they're being managed by a different team.
They're being managed by the laboratory directorate management team.
And not by the infection prevention control manager.
No.
Now that's extremely helpful. We'll come back.
It is a little bit, but it's not. You can't get the impression that they don't know, which is, I think, one of the arguments that the microbiologists would have, is that they need to be briefed. So we have a daily meeting, so they need to understand what's going on. They need to understand what infection control issues. They don't need all the details, but they need to understand what issues are going on, so that if they pick up, it doesn't matter whether it's out of hours or during the day, because they may come across something during the day that's an issue for infection control, that they know that they have to deal with it. During the day, you would hand it over to the infection control team, the infection control doctor or the infection control nurse. And out of hours, you need to be briefed so that you do know what to do out of hours if there is a problem. And most things you can put a plan in place that will then be reviewed in the morning by the infection control team.
Before we leave this topic, this briefing, who delivers the briefing from infection control, prevention control?
Well, there will usually be an at the consultant meeting in the morning. You'd have your microbiologist. Some of those will have infection control doctor duties.
And those ones deliver the briefing?
Yes.
Right. Okay. Thank you very much.
Sorry, on the weekly meetings. So there was we put in place weekly meetings with the consultants where we would minute all the infection control issues as one particular thing on the agenda, because we felt it was important to have that all minuted. And so that would be another way of having a quick summary once a week of 1, 2, 3, 4, 5, 6, whatever it is. These are the infection control issues that we need to address.
Thank you. Now, what I'd like to do is understand your understanding of the difference between the role of an infection control doctor and an infection control nurse in the managing of infection prevention control issues.
I'm a very firm believer that people should work together as a team, and that was how when I started as a microbiology consultant, there were no such things as infection control nurses. And as that service developed, we began to work very closely together as a team. And that was the infection control doctor and the infection control nurse. And that's just that service grew. There's a lot of overlap. The day-to-day duties of giving advice on infection control is the infection control nurse, and they do a lot of education, keeping of records, they do surveillance. They are sometimes the first responders on the ward. If there's a phone call, a ward says, oh, we think we may have an outbreak, or we think we may have a problem. So they're the sort of first responders. The infection control doctor is a very important link between the microbiology laboratory and the infection control service. So you've got your alerts that go through automatically on a computer. And then you've got your unusual things, which we've talked about, that you might want to alert people about. And it's very important for infection control nurses are not microbiologists. So there's a lot that they do know and understand about microbiology because it's part of their training. But there are certain things that are out of the ordinary, a little bit unusual. And it's very important for the microbiologist to be there to explain the problem. There is a problem, there isn't a problem, explain the differences, the difficult organisms, to bridge, to interpret, if you like, the microbiology results that you have, so that you can introduce that into the equation. But there is quite a lot of overlap. But the key thing here for me is always working together as a team and understanding.
Is it fair for us to take away from that, in addition to your belief in the requirement for teamwork, that one of the things the microbiologist is bringing to the process is an understanding of what is unusual, what is not known about regularly, what is different?
Yes, I think so.
Right.
Whether that's picking it up or explaining something. I mean, there are occasions where an infection control nurse may think there's a problem, but then when actually you sit down and go through it, there is.
But I think we're going to come to one of those later on in your statement.
There isn't a problem, or I mean, they're very good and they're very well trained at doing the routine stuff and things that they understand.
Well, why don't we go to that example you've given in your statement, which is a paragraph 148, which at an approximate guess will be somewhere like page 50 if we take a leap. Yes, so this is the paragraph that begins, about this time I was covering a weekend on call. Now, this is quite a complicated story, so I'm going to ask you first to put it into context. When is this?
I can't remember exactly. I mean, I lost all my records when I retired because I wasn't.
So what were you doing? You were on weekend on call.
So I was working 2 days a week, and I was doing no on-call. So once Dr. Peters was appointed as a microbiologist, infection control doctor to the board, I think that was in 2014, complicated story, but I didn't job share with her, but she wanted to work part-time. So she did 3 days and took on my on-call, and I just did 2 days a week with no on-call.
So this would have been...
But so this incident must have been around 2018, I think the end of 2017. So, but occasionally when we were really, really short-staffed, I would do a weekend on call.
Right.
And as it happened, I was on call this weekend because there was nobody else to do it.
Right. So on a Friday, you describe in the third line, you got a phone call just at the end of the working day advising you there'd be a total cessation of orthopaedic services across the health board area.
Yes.
Was that an unusual thing?
Oh, absolutely. Yeah.
And why do you think, and you explained it in this detail, but can you explain it for us again? I want to ask you some questions. Why did it occur on this occasion? What had happened?
Well, I was told, I was told that there was an outbreak of resistant Pseudomonas in orthopedics, and the orthopedic services had been, the wards had been shut and just to be aware of that for the weekend.
That seems quite a big thing to be just aware of for the weekend.
Yes, well, this was one of the occasions where the team, if you like, were coming in on Saturday to infection control doctor,
Right.
senior managers, infection control nurses. Everybody was in on Saturday to manage that. I just needed to be aware of it. I was not, well, I would say I needed to know in case something came up, and I would have contacted them. But
they were planning to be on the next day anyway.
They were. Everybody was going to be, including the chief executive.
We go to the next page. And you describe in the next page that the chief executive came in and that your registrar was contacted Professor Jones to collect some information. And what did you do on the Saturday when all this is going on? And what did you find out?
Well, on Saturday morning, obviously, you're down from two from about 7 people. So you've got the routine service to run, which is why people were coming in. I'd had a phone call from one of the directors. I think it was one of the directors of surgery, a manager, not a clinician, to say what is going on. And I said, I'm sorry, I don't know the details, but I will find out the details and I will get back to you. In the meantime, Professor Jones contacted my registrar and asked him to print off all the results for the patients that were involved in this outbreak. So he went off and did that. So the two of us are sitting in a room. I'm carrying on with the routine work. And by the time my registrar had printed off all the results and I said, look, just lay everything out. I then went and looked at all the results, and it took me maybe 45 seconds, a minute. I looked at it and said, this is not an outbreak.
And why was it not an outbreak?
Because they weren't the same organism. So there were 1, 2, 3, 4 different, 5 different organisms. So they were just not the same.
They're all pseudomonas, but they're just different species.
Yes, different species, different sensitivity patterns. I mean, one way of looking at an organism is to see if it has this one got the same antibiotic sensitivity pattern as the other one. And if they're resistant, that's a clue that they're the same. And the reason they've been shut down is that they were.
The reason the services have been shut down.
The reason was because they were thought to have an outbreak of a resistant Pseudomonas,
which would be quite a serious thing.
Yes. So the wards had been shut. Patients weren't allowed to go home, which was ridiculous. Some of the doctors were saying they were too frightened to go onto the wards, which again was ridiculous. They cancelled all elective surgery for the following week. I mean, was it important enough a decision that, Jane Grant, chief executive, was coming in because they were worried about shutting the whole of the orthopaedic services for the West of Scotland down. So I got the results printed up, and when Professor Jones arrived, I showed him the results. I said, I don't think this is an outbreak. And he said, no, you're right. And he went off and the services reopened again in the afternoon.
But what lesson do you take from this about the structure of a IPC team?
Well, my feeling was, and I expressed my concerns, I said, we really need to understand what happened, that decision was made to shut down the services when there wasn't a need to shut down all those services. And there must have been a huge cost to the whole organisation and patients as well, who'd have their operations cancelled and everything else. We need to understand. So I don't know what happened. I never got any feedback about what they found. I assume they investigated it, but I think it's an example where maybe there wasn't an input from I don't know whether a microbiologist wasn't asked. If a microbiologist had been asked to look at those results.
Can you imagine a situation where a microbiologist wouldn't have said these aren't related? There's too many negatives in that question. I'll re-ask it.
I know. Yeah. Okay.
Can you imagine a situation where a microbiologist would not have realised these cases were not related?
I would say that you could show those results to a non-microbiologist and they could look at them and say they were not the same, in my view. But no, I mean, I think any microbiologist should have realised that those results were, it was not an outbreak.
Okay, if we can take this off the screen, thank you. What I wanted us to do is ask you about something that appears later in one of the reports following your whistleblow, which is the concept of infection prevention control being a nurse-led service.
Which whistleblow?
It's the response to the report of the investigation into stage 2. If it's not something that you remember, we'll come back to it later.
Mr. McIntosh, can I just interrupt you? We have the benefit of Dr. Redding's paragraph 149.
Yes.
But I just that, maybe a repetition of your question, what is the lesson that Dr. Redding
certainly
learned? Because I think what I take from that is that a microbiologist should have been asked, or would have been a better outcome if a microbiologist had been consulted earlier. But I don't think I have got the connection between the management structure and the failure to involve the microbiologist at the weekend. It's no doubt my fault.
Given that you haven't had a feedback from your observation at the time that this should be investigated, are you able to draw any connection between that event as an example and your criticisms of the management structure that was brought in after the veil of Leven when the new infection prevention control team was created?
I don't think you can completely blame the new structure. Even under the old structure, a decision like that, which involved closing of a regional service of orthopaedics, you should have been sure that the most senior infection control doctor and the most senior infection control nurse were involved in making that decision.
And you don't know whether they weren't?
I don't know, but I think it was, for me anyway, I mean, I know I've had quite a lot of experience of infection control, that for me, it was quite simple that it was not an outbreak. So I don't know whether a microbiologist didn't actually sit down and look at the results.
Or they weren't asked, you don't know.
Or they weren't asked. I don't know, because I didn't get any feedback on that occasion. So I don't think the management structure as such really is absolutely at fault in this situation, because common sense would tell you that for this bigger decision, the most senior infection control doctor and a senior experienced infection control nurse should have sat down and understood what was going on before that decision was made.
And so are you just using it as a cautionary tale for the importance of including microbiologists and infection control doctors?
And also that my feeling is there's a lot of the infection control is going towards more autonomous working, and I think this may be an example of where decisions are being made without the input from infection control doctors that is causing the problems here.
So what do you mean by autonomous working?
That they like to make decisions that without involving the infection control doctor.
So who's they in this context?
The infection control nurses, I think, are working more autonomously. Because there are lots of decisions, I think, going back to the team working, there are lots of decisions that can be made, but there are certain times when you need to have the input and the discussion with microbiologists and infection control nurses.
So you would discourage the idea that infection control nurses should be making decisions by themselves?
On this sort of thing, yes.
Yeah. Because there is a general move in medicine to empower senior nurses with experience.
Yes.
And we've seen in the last 20 years the growth of the nurse consultant and the clinical nurse specialist.
Yes.
So why can't such a thing happen in infection prevention control? What's wrong with the idea operating just as it does in many other specialisms across the hospital, of having senior nurses with many years' experience, perhaps with master's degrees and things, making decisions quite a lot of the time without doctors involved.
There are lots of decisions that they're perfectly capable of doing, but this is where the interpretation of the microbiology results like that should not be left. That isn't their expertise, understanding complex microbiology results.
And I'll come back to the nurse-led service quote when we pick up your stage 2 whistleblower, because we will get to that document
Right,
later.
okay.
It's probably easiest. What I want to do now is to move on to your role in the planning for the new hospital. So this is a long time ago. And I won't go to your statement. What I'll do is I'll take you to a document and see if you can connect it, if you recognize it, because we gave you a document list in advance.
Yep.
So hopefully you've seen these before. Can I look at bundled 27, volume 4, document 2, page 11. So I just want to check that this is the paper that you produced for the independent review on the proximity of the Shield Hall sewage treatment works to the hospital site. And you did this presumably in about 2019.
Yeah, April 2019.
Right,
Yeah.
okay. Now, within the paper, I won't go to the page because we can read it, you raised the issue about there being concerns about the Shield Hall sewage works being known to have overflowing sewers. And I wanted just to discuss, well, in fact, let's go to the next page. I'll make sure I'm on the right page. This is on page 16. You've pulled a reference to a 2002 paper by the Health Board on the impact of the proximity of the sewage works. And that's in the first half of the bold paragraph. And then below that, you've reported there are reports of 29 sewage works plants across Scotland rated as poor because of sewers overflowing, leaking, and breaching environmental limits. And then you've mentioned that Glasgow is included on this list. Can you tell us what this list is talking about? Are these reports from 2002 or a long time ago or more recently? Can you help us?
I can't remember now, and when I went back to look at it, it had disappeared from the website. I was given this link by a friend, and who's, because lots of people I think have brought up the risk about the sewage works, and I don't know whether that's significant or not. Again, I think that would need to be an expert that commented on that. But this was just a report that mentioned that there were that a lot of the water companies across Scotland were in breach of the regulations.
It would make a difference if it was breaches that were around 2002, which could have been known to the site selectors, or more recently, which they wouldn't have known. And we wondered if you could help us.
I can't remember now, because I did go back to look at it to refresh my memory. So this was a report that was written in 2002. I think that's the
Yes, that's the site selection report that was done at the time by the Health Board to choose the site. So that's we know that's a decision point. You're saying you can't tell us whether these 29 reported plants.
I can't remember what date that refers to now. I did go back to look at it again, but I did look at it at the time, and I can't remember exactly. And when I went back to look at it again, it had disappeared. I couldn't find it.
Well,
but that's probably me, because I'm not very clever at finding things like that. But
okay. Well, if we can take that off the screen, I want to ask you a couple of questions about your memory. You obviously were involved in providing microbiology services to the Southern General site in your previous, before the merger of Greater Glasgow Health Board. That would be part of the your responsibility?
Well, I worked at the Victoria Infirmary for many years before moving to the Southern General
Yeah,
site.
so when you moved to the Southern General, when would that have been?
That was
Approximately.
about 2008, wasn't it? I
Right,
think it's
so-
in my statement. I think it was about 2008.
Yeah. So in the period from 2008, do you have any recollection of there being any issue of suspected environmental infections in that hospital connected in the minds of the people who were investigating them to the sewage hall treatment works?
No, my colleague who worked at the Victoria with me, consultant colleague, he was on the water committee, and the one thing that there was a constant problem with because we did the whole site even though we were based at the Victoria, so he was on the water committee for both the Victoria and the Southern. The problems with Legionella were well recognised, and he was the one who said at the time that we need to make sure that there is a clean water supply in to the new hospital
So
because of the contaminate. I haven't got any more detail on that because of the concerns about the water supply to the old Southern General.
right. So you remember there was a concern about the supply into the site,
Yes.
and if the fear was Legionella, that would have been the possibility it would grow within the system on the site.
Yes.
Were you aware of any concerns about infections linked in the minds of those who are working there to sewage treatment works?
No, there didn't appear to be any concerns along those lines. There were we had fewer services there on the Southern General site at the time. We didn't have the kids. Once the new hospital was open, the Western Infirmary shut, and so the whole dynamic changed.
So it's a different type of patient.
Yeah. I mean, there were still hemato-oncology patients, adults, but no bone marrow transplant people.
So we had evidence yesterday. So when you're at the Southern General in 2008 and the new site opening, there would have been some hemato-oncology, but they would have been adults and they wouldn't have been bone marrow transplant.
I think that's correct, yes.
Yeah. Was there any issue with smell at the Southern General site?
Oh, yes.
In what way was that a problem?
Well, periodically, the smell could be absolutely overpowering from the sewage plant.
You've mentioned various involvements you had in the procurement of the new hospital, and I'm going to show you some documents in a moment. But before I do that, at any point before the hospital opened, were you involved in discussions about whether the hospital should have natural, forced, or mixed ventilation?
I was involved at the very, very beginning of the whole project because the health board realised that was an important part to have infection control involved. And I met with a ventilation company. I don't know if it's the ventilation company that then went on to put the system in place, where they arrived and they said we could not understand why everybody talked about the smell until we opened our car doors and realised what people were talking about. So I was involved in that meeting with estates and other people from GGC. And at that point, there was a lot of discussion about whether it was a sealed building, whether we could have fresh air, windows that opened, whether it had to be a sealed environment, we had to meet EU regulations. And that probably is the only discussion that we had around that. It's a very preliminary meeting and they went away to consider options. And then at that point, I gave up as being infection control doctor after that.
So you gave up in 2008?
Yes.
So it's before 2008?
Yes.
Well, that means I don't have to read you a long list of companies that were involved after 2008 because it can't have been them. Yeah. There is, however, a document that we would like to show you, actually, which is Bundle 14, Volume 1, page 75, which appears to be a minute of a meeting. Now, it's not a meeting you're at, but you're mentioned in it. And so this is a meeting that, according to the minute anyway, took place on the 18th of May 2009 at the Hillington Project Office. And it discusses the new South Glasgow Adult Hospital And in the section on isolation rooms, it informs us that the group reviewed the paper produced by Doctors Redding and Hood and Annette Rankin. We can't find the paper. Have you any recollection of what your paper might have been covering other than what's set out as their ultimate decisions at the meeting?
Well, it must have been a document that was produced before 2008. My recollection is that right at the very beginning of the planning, we'd had discussions that we needed to involve everybody, the clinicians, the states, infection control, and have plans for each area, each ward, because we'd learnt previous mistakes that have been made with building projects like the New Victoria. And so we had decided that what we needed to produce was a document that looked at the spec for a domestic services room, a standard room, and different kinds of isolation room. So very, very broad discussions. And then each ward would then have to decide with the clinicians what type of patient was going to be cared for on that particular ward. So ITU, how many positive pressure rooms and how many negative pressure rooms did we need, and that sort of thing. But we never got into that absolute final decisions on that. But the decision, the plan had been that once you made the decision, you could then go and say, well, that's a negative pressure room, for example. This is the spec that we need for that negative pressure room or positive pressure.
Mm-hmm.
That was all laid out. So every single negative pressure room across the whole building, positive pressure room, standard room, treatment room, all the treatment rooms were the same, all the DSRs were the same, everything was the same throughout the hospital once the decision had been made, but you needed to have input to decide which type of room for which particular area. Does that make sense?
It makes sense. Is it on the assumption that effectively you're going to set these definitions out, and then the contractor's going to build that specification?
First of all, you need to make the decision as to what rooms, and then. I mean, I didn't get to the stage where I would have thought that you would then have sat down with the contractor and say, right, let's go over the spec for this each type of room, so that everybody had a clear understanding what the specification would be. And I would have thought infection control should have been involved in that as a double check.
But you had some involvement at 2008 stage, as you just described.
I think it was before 2008 that we just had this it was very, very preliminary, because there were all sorts of challenges, not just in relation to infection control, but also in relation to what the regulations would allow you to do. And the EU regulations at the time, because I remember that thinking, oh, that couldn't be too expensive. There were all sorts of issues, but I never was involved after that.
Okay, well, I'm not going to go through this minute because you weren't at the meeting. What I want to do is to ask you about another document which... Well, before I show you the next document, what do you think your level of expertise is in respect of what the ventilation requirements are for particular rooms and wards in a hospital in terms of the SHTMs?
Well, I would have gone to the SHTM, and I also believe that probably Glasgow at the time, at the very beginning, did not have the absolute expertise. John Hood was probably the most experienced person at the time in ventilation, but I'm not sure if he had the expertise for such a big project. And I would always have said, you need to get an external expert in to be sure.
Because I'm wondering whether
things are right.
In the rest of the material we're going to go through in a moment, at various points you express opinions about what the air change rate should be, or what the positive pressure differential should be, or should there be a HEPA filter in various wards, and it seems important to you. And I'm wondering how you reach those conclusions. Do you reach them because of some expertise in ventilation, or from another direction? How do you get to that?
From the guidelines that are written
So you're simply
Yeah.
looking at the guidelines
Yes, absolutely.
and following the guidelines.
Yes, that's my role in bringing a lot of these things up was I was there as a conduit for raising the concerns of other people for other people a lot of the time, because they hadn't had the courage to do that. So, but I would still always go back to the guidelines, say so-and-so, why would you deviate from the guidelines?
So you're not able to tell us whether the guidelines are a good idea. You're just, I hesitate to use the word slavishly, but you're following the guidelines.
That would be my premise,
Yeah,
always, to follow the guidelines, yes.
But I'm going to show you. Sorry, my
Right,
lord.
perhaps just to state the obvious. So looking at matters in 2008, 2009, you are aware of Scottish Health technical memoranda,
Yes.
and as far as ventilation is concerned, at least, will have actually looked at that document.
Yeah, probably at the time, but we weren't down into that detail of discussion when I was involved with the ventilation before 2008.
Hmm.
We were just getting a general feel for what kind of, whether we get, I mean, the first decision that was going to be made was whether there should be fresh air or no fresh air.
Mm-hmm.
And that decision hadn't even been made. And so that would affect any other decisions that were made around the type of ventilation for that building. Does that make sense?
It does indeed, 2008. But what I'm taking from your answers, I mean, clearly your expertise is microbiology, but nevertheless, you're aware that there was guidance.
Absolutely.
It was contained in a series of Scottish Health technical memoranda, and there was one document which is now SHTM 0301 in relation to ventilation. So you were aware that there was guidance.
Yes.
But you're saying you hadn't necessarily looked at the document.
I can't remember.
Right, okay.
I would have thought I had got a feeling for it, but I cannot remember going back that many years. I can't remember whether I actually read it from cover to cover, but I was aware. I must have been aware of it, yes, because I would have gone through and seen, well, what are the different, I need to understand about positive pressure and negative pressure. I need to have that basic understanding.
Right.
But I wouldn't call myself an expert having read that document.
No.
But I clearly understood the differences that we had to, the decisions that we had to make around the differences of different kinds of room. Does that make sense?
Yes, and that suggests to me that you must have had a look at the document.
Yes, I think I must have done. I can't remember seeing that reading it, but I must have done.
Well, what I think I'll do is I'll show you a letter, an email, which is in bundle 12, document 104, page 813. Now, this is an email which we've been looking at a lot from Mr. Seaborn as part of the project team. Did you have an opportunity to read this?
Yes.
And it's not addressed to you, it's addressed to a series of people, some of whom work for the contractors and some of whom are part of the project team. And the heading is Queen Elizabeth University Hospital S-Bar Rooms Air Changes. And it's in 23rd of June 2016, so it's in nearly a year and a half after the hospital's being handed over. The bit that seems important to ask you about is at the bottom of the next page, top of the next page, which is, we had a discussion during design processes about natural ventilation, which is acceptable in the guidelines. But we asked infection control for their view and approval through Annette, and they advised against it. To be fair, Annette doesn't remember this. I think it's correct in stating the infection control person who gave the advice was Penelope Redding. This is typical of the normal approval process we adhere to at all times. Now, obviously, you can only speak to the period when you were infection prevention control, so that's early in the project, 2008. So
Yes.
Do you remember being asked for your opinion about whether it's possible to have natural ventilation?
Well, I think the only memory I have had in the discussion is again with the ventilation company.
This is
who
people
came-
who arrived in their car and they smelt the smell.
Yes, I mean that and the discussion was. I mean, one of the question, for example, was, if you are a patient who is suffering, who is having chemotherapy and you're feeling really, really sick, do you really want to have that smell on top of everything else? You know, will that make you feel even worse? Is it fair on the patients? So all that sort of discussion, but there was never a final decision made at that meeting whether there could or there could not be natural ventilation.
But you would accept that you might have advised that there's some downsides to natural ventilation.
Yes, right. Smell. I think yes.
Now, the previous part of the letter, if we go back a page, goes into some detail about what happened after you stopped being a parental control doctor in 2009. Am I right in thinking that you had no involvement in later decisions?
I had no involvement whatsoever after 2008.
Okay, so we can take that off the screen. If, for example, there is a paper that sets out the logic for the air change rate from 2009, you wouldn't have been shown that?
No.
No. Before we stop for a morning break, I want to just rather cruelly jump forward to the day summer the hospital opened and try and understand your reaction to what you found when you went into particular wards, if indeed you went into wards. So would your microbiology duties actually take you onto wards?
The only wards I went to at Queen Elizabeth were the intensive care unit and high dependency units. Those are the only ones where I had involvement.
You wouldn't have been to any other wards?
No.
No. In the high dependency intensive care units, did you form any view about the ventilation in the unit when you first went there?
Well, I only became aware of some of the problems with the isolation rooms when Dr. Peters became concerned, and I went and I had a look at the issues myself.
So she would have drawn them to your attention?
Yes.
And you'd have gone and looked at the ceilings and the...
Yeah, just, I mean, she was dealing with it. She was the infection control doctor. I was looking out of interest. I mean, I was only working 2 days a week, and I did come across infection control problems and issues, but in those terms, most of my involvement has been making sure that everything was reported up.
Okay, well, we won't go into that anyway. So one last question before we take a break is, we've subsequently learned, I think it's now accepted, that the air change rate in most of the hospital, in the general wards, is 2.5 to 3 air changes an hour. And there seems to be a debate about whether it should be 6. And I just wondered if, when you were in the hospital, before Dr. Peters brought this subject to your attention, you had any awareness of the lower air change rate in the wards you were in, including high dependency and ITU.
Well, before Dr. Peters ever started, I was made aware, and I think it was possibly Dr. Inkster, that the air changes in the hospital were 3. I thought there were 3 and not 6.
But had you noticed anything about the air yourself?
No.
No, right, okay.
No. So it was just what was being reported to me. We have found such and such.
Okay.
Yeah.
What I'm proposing to do now, my lord, is to take a short break here for the morning break and then pick up the next section, if that's appropriate.
Right, we can do that. Dr. Redding, as I said, we usually take a break about this time. Could I ask you to be back for 10 to 12?
Yes.
Please stand.
Ms. McIntosh.
Thank you. So there were two questions that occurred to me after the break about something you talked about earlier on. At the very beginning, when I asked you about the role of a microbiologist, you mentioned there were 4 key aspects to the role of a microbiologist, and to my memory, you only mentioned 2 or 3. The first being the lab work, the second being advising clinicians. What were the other 2? So you did say there were 4 key aspects, and then
Right.
are there 4 key aspects to work of a microbiologist?
Well, I would say there's probably more than 4, but
Yeah.
the main one, I suppose, in broad terms, then you've probably got the work in the lab and ensuring that the lab does the right investigations and the interpretation of the results. So quite often, one of the biomedical scientists will come to you and say, this is what we've got. We then have to make a decision as to what is reported. So we have to make a decision of what is relevant to go into a final report, and also what, for example, if necessary, what antibiotic sensitivities you will report
Right.
if required. And then you've got the interaction as sort of touched upon with clinicians. So you obviously do not phone out every result, but there are certain things that you would have to make urgent contact because urgent.
So you're doing the lab work, you're validating and checking up on your team effectively.
And reporting results, yeah.
Working out what to report, speaking with the clinicians. Anything else that stands out for you as a key role?
Giving antibiotic advice on,
Yes.
and also on treatment and maybe modification of treatment if the treatment isn't working, and the management of patients and whether it requires an infection control input or not.
Right. Okay.
Oh.
Those would you consider the main ones anyway?
I think so, yes. Yeah.
Okay. The other thing is just thinking about your evidence about the role of infection prevention and control doctors. And I was thinking again about how microbiology is clearly a specialism with a career structure and with a training program. Is infection prevention control from a doctor's point of view a role that in effect any microbiologist can fill, or a specialism which requires particular training over and above the normal microbiological training program?
Well, when I started, there was no such recognised role as an infection control doctor. So I very much learnt on the hoof. And at the beginning of my consultant career, there were no infection control nurses. So I just provided the infection control service, if you like, to the Victoria Infirmary at the time and its allied hospitals. As the years went on and the infection control service developed, there was some formal training. You could go to conferences and things like that. So I went on the hoof.
But the people who are younger, how would they learn now?
There are courses and things that they can go on. I can't tell you because I've never been on them, but I did most of my stuff through conferences, but there are courses that they can go on. There isn't a formal training as such, I don't think.
So at the time you left, a new consultant microbiologist could, if they wished, do infection prevention control sessions as an IPC doctor?
Yes.
And there was no formal additional structure? No
formal training.
Right, I'd like to move on to the topic of HI scribe.
Just again, from my note, when you left is the way you put it now. Dr. Redding has explained that she hasn't had an infection prevention and control role since 2009, but she retired in 2018. Is it 2009 or 2018?
Yeah, so when you stopped being a consultant microbiologist was when I was asking about.
Yes, in 2018.
Yeah.
I stopped being an infection control doctor in 2008.
So when you stopped being a consultant microbiologist, would the new young consultant microbiologist coming on at that point have required, as far as you know, any particular specialist training to carry out IPC work?
No, usually what would happen is that somebody was usually offered the opportunity to take on. So you have your number of job sessions, if you like, as a consultant microbiologist, and you might be asked, would you like to do some infection control? And instead of doing clinical microbiology, 2 of those sessions or 3 of those sessions might be for infection control. and then you usually started learning on the job, and you're learning from more experienced ones, and you might then be going on courses. Colindale run, well, it's not Colindale anymore, but you can go on a course for an infection control doctor, but you don't normally have any formal training before you take on those infection control doctor sessions.
See, and then a session is a half day, effectively. From
Yes.
the point. Right.
Yes.
Now, what I want to do is to turn on to HI Scribe. Is this something you were familiar with when you were working as a microbiologist, or would it only have been around when you were, from your point of view, when you were infection prevention control doctor?
I was not really involved in doing HI scribes on the whole. This is, they developed.
What I want to do now is to turn to in your statement, you talk about the role of the working culture and the effect on the procurement of the hospital, or the poor working culture in the hospital. And this is in paragraph 21 of your statement. And I don't need to put it on the screen, but what I want to do is to ask you what role the working culture within what was then the Southern General University Trust, becoming Greater Glasgow, played in your decision to resign as clinical director from the laboratories directorate in 2011.
The culture, the reason I resigned in 2011 was not in relation to the culture.
Right, okay.
Okay. I had resigned, I was clinical director when I was at the Victoria Infirmary, partly because of the culture, and partly because there was a refusal, the Victoria and the Southern were merging, and partly because of the refusal to accurately record concerns and things that were being raised. And at the time, I felt I wrote a statement out and read it word for word, and then handed it to the minute taker, so there could be no confusion as to what I had said. And so that was the reason. And so that was partly culture, I suppose, because you were not allowed to express a difference of opinion, and it would not be recorded. 2011, I left because I was thinking of retiring, and
So it's different reasons.
Yeah, it was nothing to do with the culture. The culture was still a problem in the background, but that was not the reason for me retiring.
So the criticisms you make of the working culture in what is now Greater Glasgow and Clyde Health Board in the years after 2008 in your statement, are they the same sort of problems that you've just been talking about, or is it a different set of issues around what's the primary problem in the culture that you're concerned about?
Well, I suppose it depends what you include in the culture. There's very much a culture of not putting things in writing, not putting things in emails, not recording things in minutes. There is an atmosphere of intimidation and bullying, and people being afraid to speak up, which is why I, in the end, took the position that I took, because I was coming up for retirement. I really didn't need any aggravation. I was hoping to sort of slowly unwind on my 2 days a week. But people would come to me, because also I'd had the management experience, so I was able to say to them, look, this is what you must do. You must put things in writing. You must record your concerns. I made sure that everything was minuted in the consultant meetings. You need to make sure that you go through the probably management reporting, reporting lines, all your concerns. And then I started perhaps speaking to the senior managers.
Can we do that bit separately? Can
Right,
we come
okay.
back to that? Because there's a lot in what you've just said. So when it comes to the first thing you said, you mentioned your first concern was concerns not being minuted.
Yeah.
You've said the same thing about that being related to your decision to resign when you were at the Royal Victoria.
Or Victoria Infirmary, yes.
Victoria Infirmary. Is that the same sort of problem that
Yes.
you see as a continuum or
Yeah.
separate?
No, it's the same sort of problem.
And at the time, you described how your approach to that was to write things down and read them out and hand them to minute takers.
I did that on one occasion, yes.
Yeah. And you've just described how that's become your advice
To put things in writing.
to other people.
Yeah.
What reasons can you see? Well, firstly, how would the discouragement to put things in writings, what form would that take?
Do not put anything in. Do not keep sending emails. Do not do not minute this meeting.
Would a reason ever be given for that instruction?
We don't want a record of it, I think was probably said on one occasion, but on the whole, they didn't give a reason. They just said, do not do it.
Why would a record not be wanted?
Well, my view was, and what I would say to people, that if you have not put it, if you have not recorded something and you've not put it in writing, if anything arises in the future, people will deny that they have been told. So if you have a concern, you need to put it in writing so that it's on record that you have raised that concern. That was my advice.
That's your core advice. Yeah.
So core advice that I took advice from the GMC and the BMA and things as well about that you need to put things in writing and record.
And so why do you understand that the requirement to put things in writing is connected to the professional duties of a doctor then? If you took the GMC, what's the connection in your mind?
Well, in my mind, if you have a concern, you have a responsibility to patients to ensure that everything is safe in the delivery of a service, and you take an oath when you qualify that says that if you have any concerns that harm could come to patients, it is your duty to report it. And that, I think, is what I feel is your duty to do. And the only way to do that is to put it in writing, because they will be the first people that turn around and say, you never told us.
Well, we'll come to when you actually did
Yeah,
this
yeah.
in the most recent example in a moment. But you then mentioned that you felt there was a culture of bullying and intimidation.
Mhm.
Speaking, what sort of form would this take from your perspective?
I mean, personal bullying or
Either. What?
you might be shouted at. You might people would criticize you. You might all sorts of formats. Shouting is probably one of the things people were terrified of speaking up.
And when you say speaking up, is that this writing, putting things in emails and writing them down and drawing attention to things?
They would, yeah, they would, on the whole, I would say that's what you need to do. I can't say whether they did it every single time, but that would be always my advice. If they come to me and they say, we're worried about so and so, da 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 da, nobody's listening, nobody's doing anything, I said, you need to put it in writing and send it up the management lines. You have to make sure, and if you can't at the first level, if they don't listen, you have to try and move it up to the next level. And that was always my advice, so that it was in writing.
So I'm keen to keep this at generalities rather than doing too much of individual names at this point, unless it's essential. But if you're thinking, by the time you retired, you're probably the longest serving microbiologist in the health board. So I take it, therefore, that some of the people who you have mentioned in your statement as doing things you don't approve of, as it were, in this context, would have been younger than you and newer to practice. Is that a fair observation?
Not always, but
Some of them.
Most of them, yeah,
Yeah.
some. I mean, there were, yeah, it was a culture of bullying within the organisation. Some were older.
So
yeah.
do you see this as learned behaviour, effectively?
Well, it was a culture. If you just forget about microbiology, there was a culture of that within the organisation. There's absolutely no, right from the top, right the way down.
And you're sitting here in a public inquiry saying this, and under a measure of protection, because this is a public inquiry and you can say things. Why should we accept that this is something that you have seen? Apart from your own acceptance, we'll come to in a moment, what's your evidence for that?
Well, one of the things I lots of people can speak to it. I think that's one thing. There are lots of people who speak to it, and also the fact that I ended up being involved because people were afraid to speak up, and so that we, in the end, the whistleblowers were very much lone voices, and we were very much criticised for what we did. And people forget that what we were doing a lot of the time was not expressing just our own views, but the views of a number of our very senior, experienced colleagues. And we learned
who weren't speaking up.
who weren't speaking up. And one of the things that we learnt very early in this whole process was that we would not go and if I raised concerns, I would say, look, oh, so and so are raising these concerns and they're worried that they're not being listened to. What would then happen is that person would be challenged for me saying, oh, Penelope says blah, blah, blah. And they go, oh, no, I never did.
So they would speak to Penelope, and Penelope would say, "There's no issue."
Well, no, sorry, I'm Penelope.
I thought you were using their name for something.
No, I'm not using their name. So they would go and they would. One of the managers or senior people would go and challenge them. I hear you said so and so, and they would then deny it. So in the end, the whistleblowers were very careful about not mentioning people's names,
Right?
Because that only increased the stress on them, because they were then subject to bullying, and so we only put forward information for which we had the evidence to support what we were saying. And we wouldn't say so and so said this or so and so said that, because we felt from our credibility point of view that we wanted to be sure that what we said was supported by evidence, and not people say, oh, well, you said that, but they've denied it. Your colleague denied that they ever said that, and that sort of reduced the credibility, if you like, of what we were saying.
Well, could I ask you to go to page 87 of the statement bundle, paragraph 75? You're discussing at this point, paragraph at the bottom of the page, some discussion that you decided to contact Grant Archibald and David Stewart after some concerns. And this is late to 2014, early 2015, you say. How sure are you about that date?
I'm pretty sure it was just before Dr. Peters started, because Dr. Peters, I remember saying to them at that meeting, you are very lucky to have Dr. Peters, who is very experienced as a consultant and as an infection control doctor. And at the time, one of the concerns that I was raising with them at the time was their lack of experienced infection control doctors, which I said was a risk to patient safety, because there was a gap with people with not much training at the time. I said, you're very, very lucky. So I'm pretty sure it was around the time that Dr. Peters was appointed, and I think it was just before or maybe just after, but it was very much around that time. I'm pretty sure about that.
Because in the next few pages, one of the themes about these communications you describe is mucor being an issue. Now, I have various documents to show you that involve communications with Grant Archibald and David Stewart, but they don't mention mucor. And therefore, I'm assuming the ones I have are from later, when that wouldn't have been on the agenda at all, because there's nothing mentioned in the later documents. Did you see any sort of minutes or emails from these meetings, the ones you're describing on this page, the next page, that recorded what you'd said?
What I would have done after the meetings that I had with Grant Archibald and David Stewart were not minuted. So what I would always do after, because they were, you might say, informal. I mean, they saw me because I'd been a senior manager and they had worked with me before. I'd known Dave Stewart and Grant Archibald for many years. What I would do after the meeting is summarise what I had said in an email, just to confirm, so that there was something down in writing. Now, what I don't know, I have not got access to any of my emails from that time since once I retired, I lost all my access. I don't know. I mean, some of these documents that I've seen have been provided. I don't remember writing some of them, but I would have expected I would have done, but I can't guarantee. There may be another email out
Okay,
there.
what I can do is I'll go on to the oldest one I can find.
So can I just comment that both of them no longer work for the organisation, so it is quite possible that if I sent the email to Dave Stewart and Grant Archibald, it is no longer available.
Well, indeed.
Because somebody else hasn't been copied into it, maybe. I don't know.
So I want to go to a meeting that we do have some
Yeah,
record
okay.
of, which is in bundle 14, volume 1, page 463. And it's the beginning of a thread. And this email appears it's September 2015. It's from you.
Yeah.
And it's an email summarizing a meeting you had on the Monday. As you
Yep.
just said, you sent an email summarizing the meeting, and this is one of them, it seems. This one doesn't mention Mucor, so I'm assuming it's a later
Yes,
communication.
this
Is
is
that right?
after that. Yeah.
Now, what I wanted just to see is, from my reading, is this a meeting effectively about the isolation rooms in the hospital?
It appears that that's the only thing that I'm addressing in this email,
Yeah,
because that was one of the urgent concerns that both the microbiologists had and the infectious diseases people had about were they involved at this point? Maybe not. I had the decision. I can't remember.
Well, the
But
reason I'm
certainly
asking,
microbiologists.
the reason I'm asking about this is obviously we can read what it says, and we see from the following page a response from Grant Archibald to you, and you forward it on to Christine Peters, which is presumably why we've got it. But the reason I wanted to check in here is this concern about isolation rooms. Is this potentially very much the beginning of your concern about isolation rooms that later feeds into your more formal things in the SBAR and so on and so forth?
Yes, I think this is the concern that was being raised by the microbiologists on a regular basis. Is out of hours, you would get asked, we have a patient with so-and-so, where do we put them? With somebody who needed isolation. And we would go, well, you should have been able to say, right, you need to put them into this isolation room or that, that isolation room. But the microbiologist felt that especially, including during the day and out of hours, that they did not have the information they needed on which rooms met the criteria for isolating particular patients. So this was one of the common themes.
Should there not have been a list that says this room is a positive pressure ventilation lobby with this pressure differential? It's suitable for these patients, Shouldn't that be written down somewhere?
I would have thought so. That's what we were asking for. We were saying, surely it cannot be that difficult to produce a list that tells us room 1, 2, 3, 4, 5, 6. These are the standards for those rooms.
And there wasn't one.
No.
And I noticed that 3 paragraphs in the bottom, you state your view that a respected expert might help to clarify the situation. This seems to have been a theme of your communications.
Yes.
Why did you feel back in 2015 why a respected expert might help?
Well, it isn't. I mean, it was a bit of a recurrent theme even before then. But I felt that what we had is we had 2 different camps of people. One saying this, one saying the other.
So what were they saying?
Well, there are problems. There are no problems. What are the standards for the isolation rooms? Everybody knows what the standards for isolation room. We cannot agree. People could not agree.
So I want to just stop you there and try and understand that, because I want to get some more detail. If your complaint was, I do not know, or we microbiologists do not know what that room can do and what that room can do and who it's suitable for, and the answer is everybody knows, then you no longer have a complaint, because you know. They can be told, they can tell you.
Yeah. But this wasn't, this expert thing about all around the ventilation, because there were concerns. I think there were other issues that are maybe not even mentioned in here that I felt you need to get. I felt there were so many arguments about, there was the air changes, all these things. We needed to get somebody in to satisfy us that we actually knew what the position was at that moment in time.
Because we have emails, not involving you, where some microbiologists are asking questions of this nature, and other infection control doctors and nurses are emailing people in the project team and the contractors and getting some answers to some questions. Is your concern that wasn't producing a complete answer?
Yes. I mean, I think we need to be sure that when we raised the S-bar in end of September 17, we still didn't know the answer to this question. So I think we needed the reassurance that any information we were given was correct.
So you didn't have the information, and you had a sort of lack of trust in the answers you were getting?
Well, we weren't really getting any answers, but yes, any answers that we did get. If you got an answer, it wasn't the full answer. It didn't really fully answer the question that you were asking. This is what was it's very difficult. It's just very.
Well, I suppose the way to think about it is to think about a requirement for an isolation room. Now, stop me if I've got this wrong, but you need to know what the pressure differential is. Is it sealed? Is there some form of reading the pressure from outside? Are there filters? And what the air change rates are? And that's sort of roughly it.
Yep, absolutely.
Yeah.
Is the filter in the right way round? Does the vents work? Well, no, also, yes, very basic.
But there are probably 5, 6, 7 things that you need to know about an isolation room. Mm-hmm. And are you saying that you wouldn't get told all of those things at once?
I mean, there's so many, yes, they just weren't right. I've been in situations, and as an example in my statement, where you're told categorically, this is where we are, this is a fact, and you know that it isn't. That's happened to me on a number of occasions. So my feeling was we were really not getting anywhere. We were not getting the answers. Instead of arguing about it all the time, why don't we get somebody in from expert? So we'll sit down together and understand what the position is. And we always said, if we are wrong, we are quite happy to accept that we are wrong. If you provide us with the evidence that we are wrong, we will accept that. But we need to sit down and be sure that the information that we're given is correct.
Well, let's work through what you then did. So I want to show you a document which I want to see whether you saw at the time, because you might not have done. It's from Dr. Stewart, and it's bundle 14, volume 1, page 464. Now, this is a 2015 document, I understand, to have been produced by Dr. Stewart, I think following Dr. Peter's resignation.
Might have been. It might have coincided with me having had a meeting saying I was concerned about the culture and infection control.
It might have.
It was all around that sort of time.
And we can ask Dr. Stewart a bit more about how he came to write it. But had you seen this document back then at the time it was produced? No.
Absolutely not, no.
Okay.
Can I add, I think there's a lot of documents that I have seen and a lot of occasions where concerns have been raised, people have looked into it, but the reports are never really shared with anybody. So I had no idea whether Dr. Stewart and Grant Archibald had actually listened to what I was saying. It wasn't just me, what I was saying and others were saying about the culture within infection control, because this was never shared with me anyway.
But you've read it subsequently when we showed.
I've read it too as part of the inquiry. Yeah.
Yeah. Now the reason I want to show you one particular bit and get your comment on it, because it struck me as one that I want to ask Dr. Stewart about when I get to him. It's at the bottom of. Let me get to the right page. The bottom of page 464. And this is a section which appears to be of general findings, and the final paragraph on this page does state there is also a need for greater clarity around levels of accountability in the decision-making process, especially where there are conflicting views and opinions. On the one hand, there are reports from ICDs of having their professional authority undermined by the overturning decisions by the IC management team, while on the other hand, there are reports of ICDs not taking decisions when given the authority to do so. Now, I'm not going to ask you about that sentence. It's the next one I want to understand. Whilst it is clear that concerns for patient safety is the primary motivator for ICDs when arriving at decisions, there appears on occasions to be a lack of appreciation by some ICDs of the need to risk assess decisions from an organisational political perspective. Given that you were involved in raising some of the concerns at this point, and you've previously been, albeit until 2008, and had ICD functions, what do you take from that final sentence, and what do you understand by it?
I suppose you could read it two ways, but I suspect that what people are saying, what he might be saying, is that the organisation there may be a problem, but you have to risk assess the situation and decide what standard how near to that a particular standard or particular, well, I'll call it a standard you want to get. So it may not be realistic for the organisation to reach, say, a gold standard, which is a word that has been used. It's not realistic to expect a gold standard with everything. That may, so that I think that it could be a criticism of an ICD, that they expect too much. So they expect the standard to be too high, and it's not realistic for the health board to deliver that standard.
You said yes, there might be another meaning. What's the other meaning?
The other, I think, and I don't think it's this meaning, but the other one would be that there are some infection control doctors who don't want to investigate things and just say there isn't a problem, so we won't bother.
And you don't think it's that?
I don't know, but that is a reality. There's nothing to see here. We don't have a problem. But I think it's more the fact that I think here, just reading between the lines, that it's more, you cannot expect the organisation to reach the standards that you expect. You are asking too much.
Because obviously we've heard on a number of occasions, indeed it happens around about this time in respect to the decision to commence bone marrow transplants in the Shahanian unit, that the need of the patients to have the bone marrow transplant is so high that it's considered, on a balance of risks, appropriate to go ahead and use a room which has still a few outstanding issues with it, and that's a balance of risks.
Yeah.
Is that what effectively, that's an aspect of what you might think is being talked about here, or something else?
Yes, I mean, it could be. Yes, I would. There are situations where there has to be a balance of risk in making some decisions, but that doesn't mean to say that you cannot try and achieve the best possible scenario for that group of patients. And maybe that's not expressing it terribly well. For example, if we go back to the old Victoria Hospital, which didn't have lots of single rooms, you might have a patient who really needed to be isolated, but they were too unwell to be put into a single room. So on the balance of risk, you would say, well, we'll have to nurse that patient on an open ward. And what we might do is block a bed. That isn't done anymore, but you may block a bed. So you increase the distance between two patients. And you have to nurse that patient on the open ward because the risk to that patient of being in a single room is too great. But if you're looking at a new hospital, occasionally in the real world you have to make some compromises, but you have to get the basic thing of the rooms right, the specification right. there are certain, it's not like you're making it up as you go along. You go to the documents and the guidelines and you follow them, in my view. I don't think it's unreasonable to, you don't move patients, like moving patients from the Beatson. The accommodation wasn't right at the Queen Elizabeth at that time. You have to, in my view, you should try and achieve a gold standard or a highest. What is a gold standard? That's a definition perhaps you need to explore, but you should try and achieve the best possible thing and minimise the risks. And I think it depends what you're talking about. In these are brand new hospital, brand new ward. The full requirement should have been there, in my opinion. That answers your question or not.
The other thing, I think it's helpful. The other thing is to understand if what is being talked about here is the importance of balancing, of looking at risks holistically, looking at all the different risks of acting and not acting, and moving and not moving. Is it possible to carry out such a risk-benefit analysis without knowing what the specification of the ward or the room is? Can you do this balancing exercise that we've talked about, where you decide, for example, to nurse a patient in an open ward or go ahead in a treatment in a room that's not entirely up to specification, in ignorance of what the actual circumstances are?
I think you need to understand the specification and the risks in the area where a patient is, and then you have to compare it and understand the risks of where you're moving them to, and then you have to decide where the risk is greatest. Does that answer the question? Is that?
I think
but I think you have to understand both situations. You can't say, well, we're worried about this, we'll just pop them there without checking that there meets standards. I would think that probably should be better than the environment that you're moving them from.
Well, I want to look at an email, which I think we've probably already touched on the substance of, which is at page 470 of this bundle. And effectively you forward it on to Dr. Peters, but you email David Stewart. And did you have an opportunity to read this before you gave?
I did, but I've read so many things. I can't wait.
Take a moment, just because I want to ask you, what was it that was prompting this email? I think you've already touched on it in your evidence, but.
So I think the first bit is back to the isolation rooms. So the microbiologists and the ID teams don't know where to put patients. So they're wanting to check again that the information they've been given is correct. And so I've cited some examples of MERS and the multiple resistant TB, which in the end that had to be moved to other hospitals within Glasgow or outside GGC because we didn't have the facilities at the new hospital.
I just wonder whether this is effectively back to what you've actually been talking about.
Yes, I mean, I think it's. I'm trying to explain. I think that there are a lot of problems, there are a lot of concerns, and there are a lot of people that are worried about it. I don't know whether that summarises.
Well, I think the important thing, the reason I put the document in was just to connect this document to your evidence. I think we've probably usefully done that. And
so can I say that I've emphasised again here, and it would be the driving force for everything that the people we've been talking about have done, and that is patient safety. I mean, that was just the driving force of anything that we have done is ensuring patient safety and doing the best for patient.
So I have a question which I was going to ask in a way that flowed neatly from the previous one, but you've actually answered the previous one, so it'll just be out of context. At various places in at this time, there's discussion, we can take this off the screen, there's discussion of the use of prophylactic antibiotics or antimicrobials on a regular basis in with patients who are in some way immunosuppressed or neutropenic. And there's a discussion that we've had in other evidence that this might have been done because of issues with the environment. And that's still something we need to resolve and reach a conclusion on. But from your point of view as a microbiologist, are there any issues that you'd want us to take account of and think about when considering the use of, I wouldn't say regular, but quite frequent prophylactics in this sort of patient population?
I think I would divide that into two timeframes, if that's okay. The first time frame is when I was actually working, and I was aware that there were concerns about the hemato-oncology patients. And I think on 2 or 3 occasions in my memory that all the children on the ward were being treated with prophylactic intravenous, and there's a difference between intravenous and oral prophylactic antibiotics. Intravenous, obviously, the side effects are greater, and it's a very, very toxic antibiotic. I felt that there may be a situation where, and that I don't think is national protocol, but I didn't go back and check that. People would just say to me that this is worrying, this has happened. And there may be a situation where you do the risk assessment, you say, at this moment in time, the risk is really high that we have problems. We need to give you need to treat them with intravenous amphotericin. My feeling there is that if that's what is having to be done, that why are people not jumping up and down saying this is not reasonable? If it's being done because you think it might be the environment, why are people not shouting from the treetops?
So you see it as sort of a red flag?
Yeah, I mean, why are people not shouting? You need to. We shouldn't be doing. We need to do it now, but we need to be addressing the issues that mean that we need to do it. If that was the reason, I'm just. And that's my view of what I was told. I wasn't directly involved with the kids. I didn't have experience in paediatrics, and as I was retiring, I decided it's better that somebody else trained up with that expertise. But I would have thought that it was, and Dr. Harvey Wood, who's been mentioned, she just did paediatrics. She was concerned that they were using these drugs.
What was the other aspect that you mentioned? There were 2 aspects that you wanted to.
Well, it was when I hadn't appreciated how when I listened to the patients and relatives, how I was aware of this, but I was not aware of all the other prophylactic antibiotics that appeared to be used, was my impression, because of the environment. And I find it hard to understand why there wasn't more concerns being raised at a very senior level about what was going on.
Okay, right.
But that goes on to the, my feelings about the whistleblowers.
Now, if we can go to paragraph 94 of your statement, page 93. Now, I'm not going to go through this in huge length because you have set out your concerns that you took to Robert Calderwood before he retired and Jane Grant after she arrived as chief executives, because you don't have the email, so we just have your statement. So we've read that. But what I wanted to understand, because it wasn't entirely clear to me, to what extent these communications addressed the issues that you subsequently raised in the SBAR.
Sorry, what? I'm not quite clear.
So in the SBAR, we can come to that in a moment.
Yeah.
You raised a series of issues.
Yep.
And I wanted just to see if there's a sort of match between the same issue being raised in this process with the chief executives a year or so earlier.
Right. Well, all the individuals, all the ICDs that resigned, were raising issues. I wasn't the only one raising issues in 20. I was just, when I spoke to Grant Archibald or Dave Stewart, I'd be saying there are a number of microbiologists and infection control doctors who are raising issues. They have got all the detailed information. They're not being listened to. They are worried. There are more issues. They're not being listened to. They are worried. And these people, my impression, and people can speak for themselves, but my impression is that the ICDs felt they could not do their duties. They could not do their duties safely because they weren't being listened to and they weren't being given the information they needed to make decisions. And they just felt it was just too stressful that they would end up making a decision that was wrong because they couldn't do their job because they did not have the information.
So this is another example of you taking comments that you've received from colleagues, perhaps junior ones sometimes, and passing it on to senior office holders who you know because you've been a manager.
Yeah.
That's obviously one way of them learning about these issues.
Yep.
Should there be another way that doesn't rely on the serendipity of a senior former manager, as it were, being willing to listen and pass on messages?
No, I mean, these people would have been reporting through their management structure, which is what I would tell them to do, because there's no point going to senior manager and they turn around and say, well, you never told. They didn't tell their line manager, you know, they had to be sure that all that was being done. And at the end of the day, that right up to, you know, the medical director would probably be the top of the tree where they would go. That concerns were being raised with a senior infection control team, which was the manager, the lead ICD and the lead ICN. You would expect things to be managed at that level, and that would be their responsibility if they felt there were concerns to report that up through the chain, and if it needed to go to the board, it needed to go to the board. No, it shouldn't rely on me, you know, having to do that. I didn't follow those lines because I didn't think there was any point, because they already knew and they already had done nothing, or they had not reacted as these individuals felt. So that's why because they would come to me and say, what do we do, what do we do, what do we do? And that's why I use my previous connections, if you want to call that, and at the time, respect I think that they had for me to approach these people, and they were prepared to speak to me. And I would say to them, you know, there are individuals who've got all the details. They're available if you need to see them.
Because what I want to be sure about is that when you raise this in your S-bar, which you're about to come to, you raise specific things. And what you seem to be saying to me is that at this stage, most of the stuff you're raising is about, effectively, it can be very, very shortly summarized as there are a lot of microbiologists who don't feel they're being listened to. And within that, there are examples around ventilation, isolation rooms, and these things. Have I got that roughly right, what you're...
Yes.
Yeah.
Yes.
And has the issue of water quality come up in these conversations by this point?
Not. I don't think I could be wrong, but I don't think it came up into. I don't think it came up in 2016. Dr. Inkster would be able to speak to that because she was the.
Well,
ICD.
it's about you I'm thinking about, because this is.
I cannot remember the water. Definitely the ventilation. The mucor was being, I think, was isolated from the air.
Because I'm thinking about February 17 when you meet Robert Caldwell.
Oh, right, 17.
At that time, would water have been on the agenda from your point of view? From your point of view, not necessarily somebody else's.
I can't absolutely remember. Sorry, I can't absolutely remember.
What I want to do now is to move on to your whistleblow, and particularly to the policy itself in 2013, which is Bundle 27, Volume 4, Document 3, page 45. and I want to go to, so this is the policy.
Yep.
Now, if I understand correctly, this policy has been substituted by a replacement policy, I think twice since you used
Yes.
this. But this was the version that you had access to
Yep.
at the time. And
Can
I've
I
writ-
just see that? Can I just see the list of, just to be 100% sure, the list of the step 2 people that you should contact?
I'm just going to get the right place because
I think it's about page 3 or 4. Pretty sure it is. If it's the one I
it's on
looked
page
at.
47 at the bottom.
Can you go on the next page?
The next page.
Yep, that's the one. That's
the one.
That's the one we
Okay.
used in 2017. Yeah.
Right, brilliant. Could you go to paragraph 13.7.2, which is on page 47? And this is the procedure.
Yeah.
Now, obviously, we're aware that you've been a whistleblower and that you've publicised the fact that you're a whistleblower, and so I can talk about you and ask you questions about it. But whether your own personal whistleblower was properly investigated in respect of you personally isn't, I think, within the remit of the inquiry. The overarching policy might well be, and the issues that underlie it probably are. And so I'm conscious that you ultimately become quite concerned about the failure in your eyes of the board to recognise your first step in the whistleblowing process.
Yes. Yes.
And so I want just to deal with that now, really by looking at this document. So this is 13.7, and there's an instruction at 13.7.1 to follow the step below. And the first step is effectively to raise the matters with your line manager.
Yep.
Now, at this point, who was your line manager?
Well, one document I've read seems to dispute it, but I think I think the line manager we picked because of the confusion with infection control and
Yes.
microbiology was Jennifer Armstrong.
Right, as the medical director.
Yeah.
Right.
You could argue it was Tom Walsh and Sandra McNamee. Just to put this into a bit of context, this was a time when all my colleagues were wanting to go to the press, and we contacted the Medical Defence Union and the BMA and the GMC, and we were told you've got to exhaust every single process within the board. So we decided to get the whistleblowing policy out, because that was the last thing we had to do. And we thought, well, what's the point of doing step 1 when we've already been reporting it to all these people? So we had a big debate about that. And in the end, we decided, no, we're going to start with step 1, then we can't be criticised, and take it from there. So that was when we made the decision to start with step 1, and we selected Jennifer Armstrong as the medical director responsible for infection control. But I think it was clear that we were thinking about this for some time, and there's a trail of emails, which I'm sure you're aware of, that we were, not saying we'd go to step 1, trying to get them to engage with us for months and telling them we did not want to have to end up going to a step 2. We tried to get them to engage before we ever just did step 1. We just didn't do it.
I want to show you some emails, one particular thread, but I'm conscious I might not be looking at the whole story. There may be emails that precede it. And if there are, I'd like you to tell me what they were, because I can't find them, but it doesn't mean they don't exist. If we could go within this bundle to page 722. No, definitely not page 722. Sorry, bundle 14. So not volume 14, volume 1, page 722. Yes. So this appears at the top of the thread to be an email from you to Dr. Armstrong. Now, what I want to do is start at the beginning, or what I think is the beginning, and find out whether it truly is the beginning. So could you please go to page 727? Now, this is an email from you, seemingly on the 5th of September, to Mr. Walsh, Ms. McNamee, and Brian Jones. And you set out your views in this email. Now, this email comes, I think, on a day when it subsequently turns out that Mr. Walsh is on holiday.
Yep.
Were you aware of whether Miss McNamee or Professor Jones were on holiday at this point?
No idea.
No idea.
I would think it was highly unlikely that Tom Walsh and Sandra McNamee were on holiday at the same time.
Right.
But I don't know for sure.
And you seem to be raising two issues in this document. But what do you think were the issues you were raising?
One was the inexperienced ICDs which was a continual thread from 2014-15.
Right.
Um,
And the second
And
section
that's it,
seems to be ventilation.
ventilation issues, yeah. I don't think water's mentioned there.
Well, I didn't think it was. I'm going to just check.
Yeah,
So if we go up the thread, so that's up the page, we have an email from you to Dr. Armstrong only 10 days later. Now, I want to check whether you had had a reply from anybody who received the previous email that we haven't got.
I can't remember, but presumably not.
I mean, the context suggests that you didn't.
Yeah, I don't think
Because
I
it
did, but I
says
can't
here-
remember for sure.
I have not even exceeded knowledge into my email, but I wanted just to check whether, for example, Sandra McNamee or Professor Jones had phoned you up, or
Absolutely not. And I mean, I think I haven't, because I said I'm disappointed that I feel I have to escalate my concerns. That must have meant that I hadn't
Right,
received
okay.
anything, I assume. I've not even received an acknowledgement of my email. so I
and
think
you're
that's
picking
it.
them because they're management.
They're next up, yes. So there was I think I was probably unclear as to what the division and responsibility for infection control was, because both Jennifer Armstrong and Dave Stewart were medical directors for the board. And I think Jennifer Armstrong had the direct responsibility for infection control, but Dave Stewart was a person I'd been raising issues with, and I'd done a lot of infection control work with him over the years. And he still had a responsibility, I suppose, to ensure that what was happening in acute, which was his responsibility, was okay. So
Right.
I probably covered it by writing to both of them.
So you send this email, and then a few days later, you send another one. We scroll up again, because at this point you're on leave.
Yeah.
So over the next page,
Yep, it's half 9 at night. Yep.
a nighttime email.
Yeah.
Was
Because
that-
I was on holiday.
Was that a particularly good idea to do a nighttime email while you're on holiday, do you feel? Why were you doing that?
Because everybody was desperate, and I was desperate to try and get it sorted out. I was only working 2 days a week. I didn't have access. I could not send emails, work emails from home. So I went in and sent the email.
And this raises more issues.
Yeah.
And then you send a third one.
Yeah.
Do we scroll up again? And you say at this point, before we go to the top of the email, I hope not to have to take this to stage 2.
Yep.
Now, you accept that you haven't mentioned stage 1 in the
Yep,
first
I
email?
accept that, yeah.
Right. Do you think that might have caused some confusion down the track?
Well, it has been pointed out to me, sort of, you don't need to say that that you're raising a step 1. I've had professionals, including somebody who gave me support through my step 3, who has a legal background, that in fact you could argue that every single time I spoke to Dave Stewart or Grant Archibald or Robert Calderwood or Jane Grant, that was me whistleblowing, even though it wasn't formally written down.
Yes, because the protection isn't. There's no magic word.
And I think the policy says you don't have to officially call it that. I think when I reread the policy a couple of days ago, I think it does say that. So the feeling was that really September 17 was not the first time that I was a whistleblower.
Yes, you would see
But
it.
in my head, I hadn't actually ever thought of it like that. But that's what a number of people have said to me.
Right, if we go to the previous page, 724, it's a long email, and right to the top of this page.
When was that? Oh,
This
that
is
was the day or the day before I sent in the S-bar, I think.
Yes.
Yeah,
So
I was on holiday again.
you're still on holiday, and this
Yeah.
then prompts a response from Jennifer Armstrong, which we see at the top of the page, 723 at the bottom of the page.
That's right, yeah.
So she's arranged for her assistant to send this to you. Her position is that she knew you were on leave, and so she's waiting until you returned. And a meeting is organised.
For the day before I'd come back from holiday, yes.
I suppose, to be fair to them, you'd shown engagement while you were on holiday anyway.
Yeah. Well, I know Dr. Peters was speaking to me in where was I? Vienna. So we had the meeting on the 4th of October, and I went in to approve the S-bar with Dr. Peters on the 3rd.
Well, what I wanted to do was to ask you about, in a sense, how much difficulty was caused by this short deadline? Or is the short deadline actually something you welcome because you wanted things resolved?
Well, it caused a lot of difficulty, but I had given them a deadline of the 11th of October. So
you couldn't really complain that it was the 4th, because
it would have been nice if it could have been when I come back from annual leave. But anyway, no, I mean, it caused the hassle, but we dealt with the hassle. And I think that's the least important thing in this whole process. Just being a whole lot of hassle. We did it. Dr. Peters prepared the S-bar. I went over it and checked I was happy with it with the other individual. And we put in the S-bar. We missed their deadline because I'd been on annual leave, but it was there for the meeting at 8 o'clock on the 4th of October.
the thing I wanted just to check with you is that, and it may be there's another set of emails out there from other people, but this thread with you doesn't read as if it's an email from 3 people. It reads like it's an email from you. So would there have been separate emails from the other whistleblowers?
I don't know. Probably not.
Probably not.
I mean, Dr. Peters would be the only one that probably would, and I don't know if I would have thought.
We can go through that with her. That's fine.
I mean, I'm sure if there were emails at the time, she would have probably produced them, but it probably just me.
So you also sent a text message to the chief executive on the 27th of September, which you reproduced in your statement.
Yeah.
Do you see that as connected in any way to the fact you received this email on the 28th?
Well, I think I'd had communication with Jane Grant when she from I think it was about the end of April when I first contacted her when she started on the 1st of April, and I felt it was only courteous to let her know that what we were doing, so that which is what I did. So I just informed her that we were having this meeting.
Well, let's go to page 732 because it's the S-bar itself. What I'm proposed to do is, well, I think this might be a good point to break for lunch, and we'll come back to the S-bar and what happened afterwards, after the lunch break.
Very well. We'll do just that. Dr. Redding, we're now breaking for lunch. I don't intend to sit again until 2:10. So if you could be back for 2:10,
yes.
that would be excellent.
Right, thank you very much. Thank you.
Please stand.